Hello, lovely people. I just thought that I'll quickly go through how to read the medication chart with you. Please remember that before watching this video, you should have read the module, the PDF file or the scroll package in medication module on your Moodle. So, what I'm going to do is quickly go through the chart. So you will find that some of the information that we're going to talk about that you might find them in the module. However, I just thought it's probably more clear if we can go through them together. So first thing you look at this as you must have read in the module that this is an NIMC, which is National Inpatient medication chart. So with in the face-to-face session, we will talk about this in Australia, in different states and territories and different hospitals between public and private hospitals. They use different charts for different things. They use different charts for the same things. For example, force risk assessments, skin assessments, or bowel charts, food charts. Every place may use different charts. They may adapt different charts, even though they're for the same purpose. However, so which is annoying because it can be really difficult for you guys to prepare. But like I would tell you about during the face-to-face section, that it's really no big deal. Don't scare yourself yet. Because as a registered nurse working in Australia, we do that all the time. So I might be working in a place today and then work in another place, particularly if I work as a casual staff or agency staff. And if I move to somewhere else, I will be moving into a different state or territories where I need to learn to adapt to different charts. And it could also be that I have a new patient with the condition that I never cared for before, and I will be picking up a chart that I've never seen. But life still goes on. We just need to learn to read the chart and keep going, which we'll talk more about it in our face-to-face session. So let's focus on the national chart. So what you can see here, what I have on the screen is an IMC chart, and you can see here it says acute. So in our medication module, you have learned about this. We have acute, an IMC, and we also have subacute or long stay, an IMC. And the only difference is where they put the boxes. Have a look here. I probably need to use a little bit of your imagination. This is a folded chart. It looks like this. So you have to fold it in half. So here you will see this is your page 1, and this is actually your page 4. When you open up, it's page 3 and page 4 inside. The cut-off section is when we print, you cut it off. So when it's folded this way, the ADR sticker and patient's identification stickers are showing up. So let's go back to here. Let's start with page 1. So again, sometimes in private hospitals, they will adapt the same NIMC. However, there might be slight changes in this page because their facilities and the resources they have might be a little bit different to what public hospitals have, and they might need to enter their prescription provider's number. So, but you will still see the same thing. Okay, so the format might be a little bit different, but don't be alarmed. They still have exactly the same thing there. Because all the changes that they make, that it has to go through an IMC to be approved. So all the essential things will be there. Okay, so here on your first page of the NIMC, you will see the first thing here is medication chart number. So, that's not what I want. Let's go back to page. Okay. So here you have medication chart number something. out of something. So, for example, if your patient has number one, if your patient has three charts, and this is the first of it, you will see here it says 1 out of 3. So we'll talk about that later in more details. And here, of course, you have facility services name, which ward you are in, and there if the patient has additional charts, sometimes they take it so we don't miss. So you know the patient has other charts and you check it so we don't miss it. So here you have on the first page, you have once only and nurse-initiated medications and pre-medications. And here you have telephone orders. So I'm just going to quickly go through what we have on each page, and then we will break them down into small segments, and we'll talk the details about each section, okay? All right, so here you have telephone orders. That means you didn't get the doctor didn't write the order for some reasons, for different reasons. But the nurses get the order from over the telephone. This is page 1. We'll come back to page 4 later. So, sorry, how about we do it now? So for your page 4, you have PRN orders. So again, you have your patient identification label here, and then you can see here it says as required PRN medications. So here the whole page is dedicated to PRN medications. So inside you will have page 2 and page 3, which are the patient's regular medications. So that will be the medication we give every day, depending on what frequency the medication is ordered. So this is different to the once only and nurse initiated and telephone order. And this one you can see it can last for, I can't really remember, but you can do the math. I think it's about 14 days. So here you see variable dose medication, VT, prophylaxis, warfarin, and then the rest of them are the regular medications the doctor prescribed for the patient. And here are the boxes that we've already explained that in the other section inside the module, so I won't spend too much time repeating them. Okay. Next. Right, so this is just another way so they do like officially they provide 2 types of medication chart formats for us to print. So you can print to open from the middle, and this is from the other side. Doesn't really matter. When you come to the section, when you come to the face-to-face session, I will explain that to you. However, this one is just a quick example of long stay, like we talked about in the module. So you can see they have moved the boxes to the side, to the very end of the page, which allows each medication more spaces to be signed. So if the patient is staying, so that's why it's a long stay. So if that means if the patient is staying in the hospital for a longer period of time, you don't have to get the doctor, and the doctors don't have to come back all the time to recharge it. Confusing? Let's look at this again. So when I have these boxes in the middle section, we only leave one, let's say 14, okay, 14, gosh, that's not what I want. We only leave 14 days to sign the medication when we give it. That means at the end of this row, up here, you need to call the doctor, or the doctor needs to be very vigilant, knowing that this prescription, this order is running out. The prescriber will have to come back and recharge it, because after this box, nurses won't be able to sign the medication administration. That means we can't give it. So you can imagine that's why it's acute, because in acute places, acute organizations, hospitals, whatever you call it, in acute places, the patients don't usually stay over 2 weeks, because by 2 weeks' time, we expect them to settle and go somewhere else, or if it's very unfortunate, they deteriorated and went somewhere else. So that means after these 14 days, your patient will, the doctor will have to come back and re-sign it and re-prescribe the order. Then you can imagine if the patient is in subacute or rehab facilities, for example, where they stay for longer period of time, they may be staying there for 6 weeks, 2 months, or a month. Then you will have to keep getting the doctor to come back and reorder the medication every 2 weeks. That's why they also have this long stay formats. If you look into the elements for every prescription, they are the same. Okay. And that's the same thing here. This one, you can see it's for the children, pediatric. So you have the same elements here on page 1 and page 4. Page 1, again, is once only, telephone orders. The reason it doesn't have nurse-initiated medications is for pediatric departments for children's. Most of the places don't have nurse-initiated medications, which we will talk a little bit more about nurse-initiated medications because what I have heard from a lot of participants, what the information people get from the online resources or from words of mouth that's they have been incorrect. So we'll talk about that in a minute. So for pediatric, for children's charts, you have the same thing. You have once only telephone order, and on the last page you have PRN, and inside you have the regular medications. The only difference that you have found, that you probably have already found, is between the children's one and the adults one is that they have this slash the diagonal thing in each box. That's because for whatever you give to the patients, to the children, you have to have 2 people checked and signed. So let's have a look at the adults one again. So if we look at the adults one, the regular one, you see there are just boxes there. For the medications that need to be double checked and signed and double signed, nurses will have to draw a diagonal line in the box and both of by themselves, and both of them sign for the medication being administered. Okay, so what types of medications that need to be double checked and signed? It will be all the injections, anything that you inject into your patient's body, including subcutaneous injections, intramuscular injections, or IV. Any injections that you give your patients needs to be double checked by a second RN and signed by the person who checked it with you after it's being administered. Okay, you can't sign anything that you haven't given to your patient. You can only sign after it's given to the patients. All the injections needs to be double signed. And S4, S8, all the scheduled drugs that needs to be double checked and double signed. Another thing that needs to be double checked and double signed is warfarin, which has made it very clear here for you. Nurse 1, sign here, nurse 2, sign here. We will dig into warfarin in a minute. But having said that, that's only for adults. For children, you will have to sign whatever you give through into their mouth or into their body by injections. It needs to be signed and double checked and double signed. Okay, so now next we are going to look into individual elements in your medication chart. Okay, the first thing is the ADRs sticker or ADR section. So ADR stands for adverse drug reactions and or allergies. So if your patient has any ADR, adverse drug reactions to any medications or any types of allergies, the doctor or the nurses should write them here. So yes, the nurses can write that when you are collecting patient's history, unless where you work in the future, the local policy say no. Okay, so what we're talking about here is just a general policy. But in the future, when you start working, you always check your local policy because depending on where you work, what specialty, uh, the place you are working, it can have different rules. So always check your local policy in the future. Okay, so once they enters the patient's it details of the drugs or medications or allergies here. The person entering the entering the information will have to sign here, print their name. So when we say print your name, that means your full name. So write your full name in a proper way, okay? And the dates when they put the things in here. Also giving you a guide that when you ask your patient, do you have any allergies? If they say yes or no, this is where you can quickly check, see whether what they say is matching the information you have here. So this is where you can verify what they say in the medication chart if the patient has one. On the top right here, you have medication chart number. So it should go like 1 or 2 or 3. So this, if your patient have the different charts. So because what happens is, as you can see, like here, you have 1, 2, 3, 4, 5, 6, 5, 6, 7, 8, 9, 10, 10 boxes, 10 medications the doctor can give. But sometimes this one can be crossed out because it has been recharted. Then it needs to go into a new chart, or the patient may just simply have more than 10 medications they have to take. So one chart can't fit them all in. That means then they have to go to a new chart. So what has happened in the past is that people don't know that my patient has multiple charts. So they will give the medications in the first chart, but miss the medications in medication chart 2 or 3 or even 4 and 5 and 6. That's why when you open the chart, you always look at these bits, make sure this is 1 out of 1 or 1 over 2, and then remind yourself there's another one or another one that you need to give. Okay, so this here you can see this is just an example chart. So on your first page here, on the very bottom, medications taken prior to medication. So this is where the doctor or whoever is collecting these medications will write the medications that the patient was taking before coming into the hospital. So they will write the medication name, dose and frequency, and for how long. Okay, so it's like morning means morning. The doctor can write morning or man, and recommended time is 8 o'clock. Night, or the doctor can write note. It's either 6 o'clock, 2000, or it can be 2200. That's why it's recommended. So this is the guide only. Here it says doctors must enter administration times. So when the doctor's written up a medication prescription, even they say QID, then they have to write the time they want you to give. They want the nurses to administer this particular medication. The reason it has the recommended time here is sometimes the doctor don't know, they're not sure, or sometimes the doctors just doesn't do their job, they don't do this, because most of the cases is the doctor will do these bits and leaving the nurses to fill in these bits. If you are new, these are a really good guide for you to have a look. But again, because it says it's recommended. So depending on the category of the medications you are giving, and also the local policy, you might be giving the medication outside this recommended time, which is totally right, and normal. Let's come here and have a closer look. So, like as you know, the doctor can write twice a day or BD, again 3 times a day or TDS, or they can write 6 hourly, to be precise, for antibiotics. The reason is for TDS, we can give 06, 14, and 20. But in some places, you probably don't want to wake up your patients at 6 o'clock. Sorry, this is 8 o'clock. So this is not a good example. Let's go some in this one. 8 hourly. or 4 times a day here. 4 times a day. So 4 times a day is supposed to be 06, 12, 18, and 22. But sometimes it's probably not worthwhile to wake up your patients at 6 o'clock. So we do have the allowance that we do have um the what do we say that we do have the allowance to move it like 2 hours later or before. We definitely don't want to move it 2 hours before, but this one you might be giving it to eight at 8 o'clock. But if it's antibiotics, we want it to be precisely 6 hourly or 8 hourly, which means you have to be giving it at 6 o'clock instead of 8 o'clock. Because 4 times a day, if you divide it into 4 times a day, it is the same as 6 hours. But when the doctor says QID, then we do have a little bit flexibility to move the day and move the time forward or later. But if it's 6 hourly, precisely, then not most of the time, particularly for antibiotics, they don't want you to move the time. Then same the exceptions like twice a day is BD 06, I'm sorry, 08 and 2000 at night. But of course, if you're giving something like steroid or Lasix, you definitely don't want to give it at 2000, 8 o'clock at night, right? Because you're going to keep your patients up all night and the night shift is going to hate you. So for BD, even the doctor says BD, you might give it to 06 and 12 o'clock. So again, this is just recommended administration times only, and what time you exactly give it, depending on the medications categories, a little bit of your experience, and also the local policy. So in the future, if you start working as a registered nurse on the ward or wherever, just make sure you double check with the senior nurse or with the nurse in charge. Okay, so apart from here, the doctor can write QD or OD or daily. That means once a day. Usually, if it's once a day, we will give it at 8 o'clock in the morning. But if it's a Claxing or heparin, sometimes even when it's once a day, we probably give it at night or 2000. So here, BD, TDS, QID is every four. So every 4 hours, they can if it's every 4 hours that you give your medication, they can write Q4H or 4/24. 24 means we have 24 hours per day. So it's 24 hours and then for every 4 hours. Every 4 hours over the 24 hours. Every 4 hours in that 24 hours time. Or they can write Q6 or Q4H means every 4 hourly, same as this one. And if it's Q6H, that will be every 6 hourly. That will be the same as equals to 6/24 or 6 hourly. Okay, so next we're going to move to this box, which again, this is what we have talked about in the module. So if for some reason the medication is not given to your patients, depending on what reason is, this is the symbol or the code we call that you put into that box. So if when you go there, the patient is not there, you can't give it, or patient is home or doing the procedure, you can't give it, you put an A with a little circle in that box. So you don't sign it because you didn't give it. So here you will write an A in this box. Oh, that's not one. Sorry, bear with me. Let me see if I can write. So you will write an A here. Oh, yes, I can. Good. And give it a little box. Okay, if the patient refused, you will write R and refused. For example, if you are giving the antihypertensives, but your patient's blood pressure is too low, it is for the nurses to make the decision saying, no, it's not a good timing to give it, I'll withhold it. And we might talk about this with the doctor or we might give it later. So in the case, you might see they put a W with a little circle in that box. I say, okay, in the at 6 o'clock, the medication wasn't given because the patient's heart rate was too low or the blood pressure was too low. Then you will expect when I open up my medication chart, I will see a withhold code or a withhold symbol in that 6 o'clock medication bit. Okay. So if that happens, and or it could be warfarin because it's outside the INR that we want to give the medication. Doctor might say, okay, withhold. So they might do this, don't want to give it. Okay, something like this. You don't have to remember them because they're always here. That's all. Okay. You might see S. S is quite common. S means that you didn't give it, but the patient had it by they give it to themselves. So it happens a lot for eye drops because if they've been giving eye drops to themselves every day, 4 times a day, 6 times a day, they'd rather do it by themselves. Or some patient, if they are insulin dependent diabetics, they've been giving that to themselves every day. They prefer to do it by themselves, and then you watch that, you supervise them giving it to themselves. So you know that they've given this. So if they just say, I've done that, you can't do this. But if you watched them, you supervised them, self-administer the medication to themselves, then this is the symbol that you put. So the next one is about the patient's weight and height. Okay, so you have to have a quick look here, particularly for the kids, because when we calculate the kids' medication dosage, we go by weights particularly. Abbreviation. So these are the abbreviations commonly seen and acceptable in your medication chart. So in the roots, your patient might say, sorry, not your patient, your doctor might say PO. That means give it to the mouth, swallow it. NG is through the NG tube. Sublingual, or sometimes they just write sublink. That means under the tongue. IV is, IV, intravenous, IM, or sometimes they write IMI, which is oh God, which is IMI. So that's intramuscular injection. And they might write SUB or SUBCUT, subcut, or just sub, that's subcutaneous. Eye drop, they might write GATA, but most of the time, most of the cases in Australia, they will write eye drop or eardrop. They'll just write these eye drops or eardrops. Eye ointments, that's eye ointment. TOP means topical. That means like ointments or the lotion that you give on patient's skin. Nebulizer, the little thing you put it into the mask and turn on the air for the oxygen for COPD. Regular medications with variable doses. So these are things like steroid or gentamicin. So we talked about this in the unlike the module information, so I won't spend time on this one. So here to read it. So they might look different, but you still you will always have your 5 rights here. You have and it's because it's illegal, it needs to be a legal prescription. So you would definitely have the place for the doctor to date it and sign it. And you have your right medication to check the route, frequency, and because it's variable dose, so every day the dose might be different. So the dose will be here. And because the dose is prescribed every day, the doctor will have to sign the dose that he or she prescribes. Okay, and time given is the time given. Whoever gave it, you have to sign here. And if it's a medication that needs to be double checked and signed, then you will put a slash here, a diagonal thing here, and you sign here. The secretarian signs the other bits. Okay, so let's have a look here. Here is the regular medications. So this is inside, right? So they might look like this. You have the dates and the doctor sign here. So in the exam so far, they were putting indication for you. So what the medication is for. Of course, to be compliant, the doctor will have to write the indication here, but in real life they might not. If they do, then that's good because you at least you get a little bit clue. If you have never seen this medication before, you can get a little bit clue from here that what the medication is used for. So which is quite useful when you need to explain the rationale to your patients, which we'll talk about during the face-to-face section. Okay, so this is roughly what it will look like in the medication chart. So there will be date by the doctor. The doctor should print their name here as well. That's usually their pager number. Medication, route, dose, frequency, and the time should have been entered here for you. So you can go check, okay, so this 9 o'clock now. This one is due, not this one. Okay. Variable or reducing doses, it might look like this. Warfarin is another thing that can be tricky. So warfarin is a high-risk drug. That's why they particularly created an independent area just for warfarin. Okay, so here warfarin is already written there. The doctor doesn't even have to enter warfarin. However, they do need to circle the brand. In Australia, two brands that we use for warfarin is Marvin and Coumadin. So the doctor should circle it. But like when I say should, if they don't be don't panic. They just sometimes they don't. They are the brands. So when you get to your preparation area, look for either this one or this one. Okay, because it may not say warfarin on the bottle or on the box because it might have only the brand name. Okay, so if they're using Coumadin, they should circle this one. And the doctor, whoever is ordering this, they will do date, the routes. So most of the time warfarin is PO. Target INR, they will write the range here. Pharmacy bit is that the pharmacist, if they come and review the medication or the prescriptions, they might write something here. They might just sign here or they might write some notes here. Sometimes they might write, oh, it's 4, it's 8, or sometimes they might write something like take with food, with meal, or take with 2 hours before meal, take with empty stomach. So this section is for pharmacy to put in whatever they want to put in there, whatever they want you to know. Indication is what this medication is for. Prescriber signature, so the doctor needs who prescribed this medication. They have to sign here, print their name here, and they might to their pager number here. And here you can see INR results to be put in here, doses here. Doctor will have to sign here for the dose, and nurse number 1, nurse number 2. This is where you put your signature. Sorry, put your initial here. And you can see here dose time 1400 or 4 p.m. Some medication chart says 1800 or 6 p.m. The reason is at either 4 or 6 is we usually take the blood in the morning, and in the afternoon the blood result will come out where the doctor can check the INR results. When they check, put it here, and they will, depending on the target INR they want and the result of the INR, they will decide how many milligram the dose that they want to give the patient. So they will prescribe the dose for that day. And because it's prescribed every day, they have to sign here. That's why it's either 4 or 6, because that's when the results usually comes out. Okay, and then you also see the little red box in the middle or on the side, which is we also talked about in the online module, so you can have a look at them. Usually you don't have to do anything about this in the OSCE exam. So this is just an example. So it might look like this. Sometimes your doctor might, sometimes you might even see it says like, okay, because sometimes the doctors probably don't want to take blood from the patient every day because it's quite cruel. So they might go, okay, 2 days, and then one day they go, no, nothing, and then nothing. They might do this, and then for that day, they just in case that the nurses forgot, they will do this. Like, make sure you check because this is the day we want to put in the blood order for the blood lady to take the blood because that's the day the patient is due for warfarin. So that means check it today, and then I will come back to prescribe the medication and prescribe the dose. And something like this, that's just the doctor saying, don't worry about today, don't worry about today, don't prick my patient, don't take their blood, but do it today. Okay. Now we're moving to the regular medications. So regular medications, you can see, let's have a look here again. So here that the doctor says to the doctor, please put in the medication time here, and sometimes they do, sometimes they don't. Hopefully they do during the OSCE exam. So far they do. So here is the date, medication, route, dose, frequency, all now. Pharmacy put their notes here, indication here, prescriber signature, their name and contact. For the medication here, it says tick if it's slow release. So if some medication, they are slow release the medication, like for example, some opioid medication, if they want to use the brands that is, they want to use the type that is slow released or modified release, they will tick it. But again, you don't have to worry about this during the OSCE exam. As long as if it says in the medication says SR or slow release, when you go to your preparation area, when you are when you are picking up your medication, make sure you choose the right one that says slow release, because they can be tricky. They might give you the same medication which is normal release, and the other one is modified or slow release. So you have to pick the right one if it says SR or slow release or modified release. So just pay a little bit extra attention to that one, what it says. Okay, now we are moving to the last page of as required PRN medication. So the same old same. You have date, medication, routes, dose, hourly or frequency, and it says PRN. PRN means you don't even, I have the frequency here, but it doesn't mean that you have to give by that frequency. You give it you stick to the frequency that you are allowed to give, but you only give it when the patient needs it. Very confusing. We'll get to that in a minute. And because they might be you might be giving more today and less tomorrow, so there is a maximum dose. If there is a maximum dose, the doctor will write it here. Pharmacist place, indication here, prescriber signature, and their name. And this is because this is not regular medication. So you have to, every time when you administer it, you have to write today's dates, the time you're giving the medication, and how much, what the dose you give, and the routes and sign. Okay. So why do I have to write the dose and routes? The reason is for the PRN, the doctor might write something like 5 to 10 milligram. For example, Endone, let's do Panadol, okay, paracetamol here. So the doctor might write paracetamol here, but they will leave the nurse, because you are the one looking after the patient, listening to the patient's complaint, and monitoring the patient's condition. So they give the rights to you to make the decision whether my patient needs a little bit less or they need a little bit more. So you might see something like this. They might write something, okay, I give paracetamol here. Of course, they're not going to write it in the middle of the thing. They're going to put it, at a proper place. I'll move it, but you know mine, you know what I mean. Okay, and then at the dose, they might put something like, let me make it smaller, 500 milligram to 1 gram. So that means when the patient complains having pain, not 1 hour, 1 gram, you will be conducting a quick pain assessment and decide, oh, okay, if it's not too bad, I'll give 500, or I'll give 1 gram if it's really bad. Okay, so this is for you to make your clinical judgment and also involve the patient in the decision. And the hourly and frequency, so the doctor might put something like QID or every 6 hourly, but we all know that there is a toxicity level for this medication that you can't exceed a certain amount, right? So for this one, we know this is 2 grams. So that means when you are looking at this chart, yeah, okay, of course, this one will be feeling like this, and they will sign here. I'm not going to do that, but here, so that means when you do, okay, and then for the roots, they might do PO or IV because we can give this as IV, right? And of course, they will put the date and the rest of them to make it a legal order. So when you are reading this one, that means you can be given 100 milligram or 1 gram as long as it has been 6 hours prior to last time it was given. Let's have a look here. So if your patient complain pain and you look at, okay, you have paracetamol written up. It hasn't been given yet today. Perfect. Okay, so you don't have to worry about what was the last time given. You can just say, okay, how's your pain? Is it really bad or it's bearable? The doctor has written 500 milligram, which is 1 tablet, or 1 gram, which is 2 tablets for you. What do you think? Do you want to get 1 gram or 2 tablets, or one is enough? Or should we start with one and see how you go? Okay, that's why when you are giving the medication, you'll be written here. So the day is today's date, and the time now I'm giving is 1400. Where's my box? Yeah, let me make my box smaller. Wait, 1400. It won't come here. Okay, come here. Okay. And the dose, okay, so we decided just to give 500 milligram. So I'll put 500 milligram. The idea, I don't know how to make it smaller, but when you are writing it, of course, you're not going to do that like this. You will be writing in the box, right? And the roots, you will be written something like, if you are giving it as oral, you will put PO here. And then you will be putting your signature, your initial here. Yeah, you can put PO so the doctor or other people know when it was given. Was it given using oral or IV? Okay. All right. So that means because the patient is allowed to have 1 gram every 6 hourly, right? So if like at 3 o'clock, the patient say it's so sorry, it's not enough. I think 1 tablet is not enough. I need another one. Yes, you can because the doctor has allowed you to give up to 1 gram. So you can actually do these the same date, here 1300, and then you give another 500 milligram through oral and sign again. I mean, initial again. And then, so that means next dose will be 6 hours from here. You can give um, another, another prescription. Okay. And you can't give more than 2 gram. If in the past 24 hours, your patient has already had 2 grams, even though it has been 6 hours, you can't give it. Okay. So for PRM, the 5 rights still the same, but to decide how can you give it, you have to have a look at the frequency and the maximum dose. For example, let's say when you go, when you are in the exam, the patient says, "Oh, I have pain. Can I have some painkiller?" You're flipping the chart and you find, okay, you've got paracetamol written up. I'll give you paracetamol, but hold on. Can you give it? Have a look here. So if you are told that the time now is 3 o'clock, if you are told that the time now is 3 o'clock, and that you are reading it, can I? I just can't do anything about this. Okay, that's better. Okay, so when you're reading your patient's chart, now, like let's say time now is 1500. Okay, so now time Now is 1500. The patient says, I have pain. You had look paracetamol. Okay, don't be too excited. It's can you must have a look. Yes, I have the paracetamol ordered for his pain, PO or IV, 500 milligram to 1 gram, and QID. Can I give it? Depends on whether it has been given according to the frequency and has this exceeded the maximum dose. So if time now is 3 o'clock, you can't give it because they was last given at 1400. It's only been 1 hour. It hasn't been 6 hours. QID is every 6 hours, right? It hasn't been 6 hours. So you can't give it. Then you have to look for other medication. That means this one is there to trick you. You are not giving this one. Okay. But on the other hand, if you come in, the patient say, I have pain, and then you come and check the medication chart, the PRN. Here last given was 6 o'clock in the morning. Yes, you can give it because 6 o'clock morning, every 6 hours, the patient can have another dose. So 6 o'clock in the morning, now it's 3 o'clock, it has been more than 6 hours, then you can give it. So you can prepare your medication, give it, and do your signature, you signing bits here. Okay. And so that's checking the frequency. If it's something like morphine, so the route could be IMI or IV, you know what I mean. Okay. And every time the patient asks for it, it might 5 milligram to 10 milligram. And the hourly will be patient is in so much pain. So the doctor say every 2 hours, as long as the patient asks, give the patient 5 or 10. Okay. However, we don't want to kill the patient, right? So they might go, okay, but for every day, you can't go over, I'm making up, okay. You can't go over 100 milligram. So then when you are giving it, you go, okay, last time it was given. And so now again, the time now is 1500. But if it's so when you come and look at this, if it says 1400, it was last given, then I'm sorry, you can't give this medication. It hasn't been 2 hours yet. If it has been 2 hours, but there has been multiple entries, and when you add it up, it's already over 100 milligram, even though it has been over 2 hours. But if over the 24 hours, it has been given so many times that your patient has reached the 100 milligram, you can't give it. Okay, so the regular medications, they're very straightforward. For the PRNs, they can be a little bit tricky. Just make sure you check the routes, the dose, the frequency, and the maximum dose if it's applicable. And also check what time the scenario tells you it is now. And if it has been given previously, what was the last time it was given? And how many milligrams or what was the total dose in the past 24 hours that has been given, and to see whether that has gone over the maximum dose yet. So it could look like this. You may have pathogen signed by the dated and signed by the doctor. Root is IM, 100 milligrams, 6 hourly PRN. So this one, the doctor say that's fine. Just give. You can give every 6 hourly. It won't go over the maximum dose. So they didn't even bother put it in. All right, let's quickly look at once only pre-medication or nurse-initiated medication. Once only means stat dose, so you give it now once. So the doctor will write the date, prescribed medication here, the routes, the dose, date, and time of the dose. So once only. So once only they might go. If it's a pre-medication, they might go 800, and then they will put the practitioner. So that if it's a doctor, then they will put the signature and print name here, and the nurses who is giving it, you will be signing here. Okay, if it needs to be co-signed, then there'll be two of you. And what time it was given, and pharmacy can write their notes here if they want to. So if it's once only, if they write stats, that means now. Doesn't matter what time it is, just give it now. Sometimes if it's pre-medication, they'll go, okay, give it at 6 o'clock or 2400, like midnight. They will write the time. If they didn't write the time, just write stats. That means now. Okay. And that's what we talked about. Pre-medication usually is before the procedure, exam or whatever. And nurse-initiated medication here, just please so nurse-initiated medication, that means in Australia, sometimes the nurses are allowed to give some medications. So I know some people have been read things online, which unfortunately is not entirely correct. Yes, we can give medications for the patient, but not all the medications the nurses can give. And what medications the nurses are allowed to give vary from every individual place. So you might have someone giving you a list of medication you can give, but have a look at that piece of paper they share with you. In one of the corners, it definitely has the organization's name. Okay, and that only works for approved by that organization. That means if that approved list of nurse-initiated medications by hospital A, you can't give those medications in hospital B unless they are approved by hospital B. Even if it's the same hospitals, even if it's from the same hospital, different wards have different specialties. They might have different approved list of nurse-initiated medications. For example, in cardiac ward, the nurse-initiated medications might contain some cardiac related medications. However, in orthopedics ward, the nurses working there, they can't give those cardiac medication to their patients. So don't think nurse can initiate all medications, which is wrong. Don't think there's one list applies to all. Okay, so it's different. Okay, so it's a legal thing and it's about your registration. Don't risk it. Okay. And it's like if you heard people say different to what I say, be really careful of what they say. Okay. Okay, so you have to know, and so nurse will have to write here if they're initiated. Next, we're going to talk about telephone order. Telephone orders is like if it's an emergency or the doctor is stuck with something that they can't come up and write the orders for the patient, but your patient needs it now. Then they can give the order over the phone. So what they do is they're going to say the patient's ID and medication, the dose, the route, the frequency for the patients. So you will be listening to on the phone to the doctor say, I'm giving to this person, so the first name, surname, date of birth, MR number. I'm giving this person this medication, the dose is this, the route is this, the frequency is this. While you're listening to it, you will be writing them down, right? And when you are doing that, you always make sure you have a second nurse right next to you. So after they say all those information, after the doctors finish with the information, you go, okay, I'm going to pass my phone to the other RN. And the other one will pick up the phone, go, hi, I'm someone from this place. I'm listening to the phone order. And the doctor will repeat the same thing, the patient's identification, the date and time, the medication, the dose, the route, the frequency. And the second arm will be reading what you have written here. And they go, yeah, sure, no problem. Then you can hand up the phone. And people hand out the phone, we usually say, don't forget to come and sign it, because the doctor will have to sign this order within 24 hours. Otherwise, I'm in trouble. We are in trouble. Everyone is in trouble. So me listening to the order, I will initial here because I took the order, and the other person that listened to the same order, they will put their initial here because they verify yes, we both heard the same thing. Okay, so this just in case the doctor turns around and say I didn't say that, you go, hey, I have a witness. And within the 24 hours, they'd better get their butts up here and sign this for us. Okay, for everyone. Okay, and then the telephone order can last for 24 hours. That's why there is a frequency here. So it's not a stat or once only dose. It can go over 24 hours. So if it's QID, I don't have to ring the doctor 4 times a day to get a phone order. That it already has QID here. So I can give 4 times over the days. And then of course, if it's like Q2H or Q4H, you can go to next line. But we're not going to talk about this for the OSCE. Okay. So the time you given, so day definitely is a day because it only lasts for 24 hours. And then you will put the time you given and given by someone, you will write your name here. You will write your initial here. If it's something that needs to be double checked and signed, you put another line here and both of you will be signing when you're giving it. Okay. So see, they might look different. So they might be once only order. So they might be once only, they might be telephone, they might be regular, they might be PRN, but don't panic. For the medication station, what you need to do is to make sure you have your five rights right. So no matter where they are writing or what type of this medication, this prescription is, they always have your five rights here and the legal elements there. So it needs to be signed and dated by the doctor, signed and dated by the doctor, signed and dated by the doctor. And then you will have your five rights, right medication, right route, right dose, right time, right? And here you have your right medication, right rules, right dose, right time, and your right patient. Okay. So when you are checking the medication chart, the first thing is you're going to verify your order. And then you will do your 3 checks for your 5 rights after you verify the order. Okay, so we'll talk more about this in the face-to-face session. Okay, so basically what you will do, you pick up the chart, you go, okay, let me verify the order. So it has been dated and signed by the doctor. Medication is this, nebulizer 5 milligram, frequency is QID, and look at what was the last time given. So and look at the time it is now. So it's 12 o'clock. It hasn't been given yet. Good to give this one. And of course, check your patient. Some examples you might see here. So it's dated and signed by the doctor. Medication digoxin, Rudis PO 187.5 microgram. The frequency is daily, due at 8 o'clock, hasn't been given yet. And this is used for patients CCF, chronic cardiac failure. The same old same is stated and signed by the doctor. Medication ampicillin, Rudis IM doses 2 grams daily, due at 8 o'clock, hasn't been given yet. It's for the patient's infection. Dated and signed by the doctor. Medication is the atropine, Rudis IM doses 800 microgram daily. This is used for patients' bradycardia and due at 8 o'clock, hasn't been given yet. If it's PRN, it's signed and dated by the doctor. Medication pathogen Rudis IM. Dose is 75 milligram. Frequency is every 4 hours. PRN when the patient needs it. Maximum dose is 450. This is used for the patient's pain. Date, and it hasn't been given yet today. So yes, I can give it. All right, and just another quick reminder that when you are reading through the medication module, we also talked about the AIH, Australian Injectable Handbook, and we in the video that I provided to you, it breaks down every section of this thing, how to read this page, how to read this information here. So make sure you have a look at you make sure you read the thing. You read the thing, sorry, you watch the video, particularly again before you come into the face-to-face session. Okay, so that's all what I need to talk about. And we will see you. You can keep working on other things until I see you at face-to-face session. That's all. Good to have you here. I will see you very soon.